something and why to take them, and how that comes from within the patient, not necessarily what we as a provider might want for our patients. So you can think of it as kind of in between something that's more directive versus a following role. We want to think of MI as a guiding role. So if you think of like on a trip, if you have a guide doesn't follow you around typically. A guide also doesn't just tell you what to do. A good guide will find out what you want to do and then will help facilitate things to get you the experience that you want. So essentially, we help a good guide will help you get what you want. A big piece of MI is setting up discrepancies between what someone's behaviors are and what their values are, and letting that discrepancy drive the behavior change. So as kind of a broad overview, MI is a way of just being with patients. It's a way to reduce provider stress and burnout because it really emphasizes the patient being in an active role. It's a way to improve behavior change outcomes. It helps place responsibility for change on patients and their families. And it can be a standalone or complement to more intensive treatment programs. So why use MI? I've kind of mentioned this on the last slide, but interventions focused on changing behaviors can often be very stressful, not just for patients, but for providers too. And so utilizing the skills that we're going to talk about today and kind of embodying more of an MI approach in care with our patients can also help us as providers to prevent burnout. It can also, unsolicited advice is typically not a successful strategy and might actually make individuals less likely to change. So this is hopefully going to give you a skill set to work alongside patients and towards change versus getting in, wrestling matches around behavior change. It can also help providers guide conversations around difficult topics like things including corporal punishment, limiting social media, weight management, sex, and substance use, along with many other things. So why do people change and why do people not change? So there's different stages of changes, and this is important to know as a provider when we're talking about change with our patients. So oftentimes people can be at different levels of change. And the first kind of stage of change is often referred to as this pre-contemplation stage. So this is where a patient is not yet considering change or is unwilling or unable to change. And so as a provider, we are tasked with hopefully helping this patient just raise awareness and start kind of planting seeds for potential discrepancies. A big thing here is we might assess the current or risks of current behavior to just, again, raise awareness of, is this a helpful behavior? Is this not super helpful? And then there's contemplation. And this is where patients might be more in an ambivalent stage where they are thinking about things. They are thinking about things, but not fully committed yet to change. So here we want to really assess. We want to first validate that ambivalence is normal. So normalize ambivalence. We can use reframing, lists of pros and cons to tip that kind of decisional balance scale. If that scale tips and you move to the next stage, you're in the preparation stage. So the preparation stage is where people are really more ready to take action. So this is where we can help identify and assist in problem solving. So like what obstacles are going to get in the way of change and how can we help set our patients up for success around navigating those obstacles. And so we want to encourage think of small goals that are achievable, measurable, time sensitive, things like that, realistic. And then we get to the action where behavior change has started. So this is where people start practicing new behaviors, and we want to focus on making sure that their environment is supporting these behaviors and that the goals, again, are realistic and achievable. Maintenance is that stage where now we have sustained behavior change and how can we keep it going? So do we want to plan for follow-up booster sessions? Do we want to talk about how to reinforce, via internal rewards, how to also setting the stage for, discussing coping and prevention of relapse. Because then if potentially patients might then get into the relapse stage, and this is where we want to really focus on reaffirming commitment and begin progressing kind of through the stages again. So really key here is like re-engage in the behavior change, and again, normalize that like relapse happens. Reoccurrence does not equal failure. So it's important to be familiar with these stages of change, because when you're talking with a patient, you want to know kind of where are they at so I can meet them where they're at, and then utilize different skills that we'll talk about today to either help the patient progress to another stage of change, or just help them even start thinking about change in the first place. So the different processes of MI, the first one, engaging. So this is a process by which both parties establish a helpful connection and a working relationship. This is key. If you don't have that therapeutic working alliance, not a lot of this is not going to be successful. So it really does. Sometimes I hear providers also talk about like, well, it's hard to build that quickly, and I only have so much time with my patients. You can build alliance pretty quickly, and we'll talk today about different ways to do that. Now, every family and patient is different, so some may take more time to be to help that rapport build more. But there are some really I hesitate to say simple or easy, but there are some really straightforward, I would say, realistic things that you could engage in a very quick session with the patient to help build that alliance. So you want to be engaging. The next one is focusing. So focus on a particular agenda or what's important to the patient regarding their behavior, their health, their welfare. So we want to focus on them, not necessarily what we want for them, but what they want for themselves. Evoking. So we want to elicit the patient's own motivations for change. As providers, we often want to kind of put our 2 cents in as to why we think things might be helpful, but that goes against the kind of heart of MI. We really want patients to be guiding their change talk and their change processes. So evoke from the patient. And then planning, develop commitment to change and formulating a specific plan of action. So once you get to that preparation stage, how are we going to help support this patient move to actually creating realistic goals that they can achieve and maintain over time? So we'll talk about this a little bit later, but MI isn't really a technique. There's this spirit of MI that you'll hear people talk about that you want to try to embody within all of your interactions with patients. So you want to be collaborative, non-confrontational. Again, you want to evoke, not just educate. Now, education is part of our role as providers, so there will be some education, but we don't want it to be all education. We don't want to be, again, fully directive. We want to be kind of in that guiding role. We want to respect autonomy, so we are not authority. We want to respect autonomy of our patients, and compassion. And I'll add kind of my own extra piece in here that is echoed throughout some other principles that we'll talk about, but being genuine about those things. So patients are going to know if you're not really genuine about some of this stuff. So be genuine about how compassionate you feel. They will pick up on it. So again, just be genuine with with the skills that you utilize, and we'll talk about that again in a few slides. So MI is not a way of tricking people into doing what you want them to do. Sometimes people refer to MI as like Jedi mind tricks. We're not tricking anybody into doing anything. We are acting as that guide. We're helping. I also think of it kind of as like organizing what's inside somebody's mind. We're helping to organize it for them, and then helping them lay it out on a pathway that seems achievable. It's not a specific technique. So today we're going to talk about some of the basic foundational skills, but there's a lot more that goes into MI. And so it's not necessarily a specific technique, and you can weave it into whatever treatment, mode of treatment you're already using in your sessions, or just in general, check-ins and follow-ups with patients. It can be just something that's embedded within the way you generally interact with your patients. So it's not a specific technique. It's not just problem solving or skill building. That's a piece of it, but that's not what MI is. It's not just patient-centered therapy. It's not easy. So what I'm going to talk about today, a lot of it seems straightforward, but putting it into practice can be a little bit challenging. So you want to practice it and build it like a muscle. And it's not a panacea for every clinical challenge. So sometimes I hear people say like, well, MI would help here. Like, MI isn't going to overcome every clinical challenge that you're faced with, but it can be really helpful in a lot of different ways. I kind of want to highlight adolescents here. So if you work with adolescent populations, why might motivational interviewing be something that you integrate into your care? Well, telling teens what to do pretty much almost like equals teen resistance. So it's a nice way of interacting with teenagers and adolescents that helps build that alliance more quickly. Information alone is not enough to change behavior, so we can educate and educate and educate. And oftentimes, and a lot of providers probably already know this, that does not equate to behavior change for our patients. And MI allows teens to drive the process. They tell you versus you tell them. So it really allows for that respect of autonomy. And that, again, helps support a really good alliance. So what are kind of the main principles of MI that we want to keep in mind? So one is expressing empathy. So empathy reflects an accurate understanding. It kind of assumes the person's perspectives are understandable, comprehensive, and valid. It's understanding someone without judgment. Developing discrepancy. So again, we want to emphasize that ambivalence is normal. And then we want to also figure out where might someone's behaviors not align with their values to help create that discrepancy that will hopefully help then set the stage for change talk and behavior change. And then rolling with resistance. So we're going to talk about this on some future slides, but there's the pressure sometimes to what's called the writing reflex. Like we want to just tell people what they should be doing or what would help them. That isn't helpful if somebody's not in the right place to hear that yet. So it's not typically a helpful strategy to just be like, yeah, but you know this is bad for you. People probably know that and they're still doing the behavior. So us reminding them of that is probably not going to be a successful strategy. And really, ultimately, it'll probably hurt our alliance with that patient. And then supporting self-efficacy. So we can talk about all of these things. However, if a patient doesn't believe that they have the capability to achieve a goal, then that's going to really knock their motivation to even try. So we really want to help support self-efficacy along the course of supporting change talk so that when our patients come up with potential strategies for change, they feel as though and they think as though they can do these things. So we're going to go into depth into each of those principles now. So expressing empathy, I mean, as providers, we can all probably guess why this is important. But again, acceptance facilitates change. So if we can, again, validate and normalize ambivalence, that can help facilitate change in the end. And then skillful reflective listening is fundamental. So showing somebody that we can imagine what they're going through or potentially understand what they're going through and repeating back things that they've told us, show that we're present, show that we have some understanding of what's going on, which again can help facilitate change. And then seeking to understand the person's frame of reference. So it sounds like, or it seems as if understanding it from the person's point of view is a way of expressing empathy that, again, helps facilitate change, helps promote a collaborative alliance, which then helps that patient be more engaged in change talk with you, and kind of helping them move through those different cycles of change or stages of change that we talked about earlier. So again, highlighting just again, ambivalence is normal. This is important for people to be validated about that. It's okay. You know that this isn't a great behavior and it's okay not to know what you want to do about it. Whereas maybe our writing reflex is like, it's bad and you should stop. That's a different approach than, this is bad and you're really thinking about this. Developing discrepancy. So again, like what is their current behavior versus what are their future goals and how does that align with their values? So a person rather than the clinician should be presenting the arguments for change. And then again, change is motivated by a perceived discrepancy between present behavior and important personal goals or values. So for example, some of the questions that could help bring up or develop discrepancy. How does your medication use fit in with your goals? How does the you as a medication user fit in with you as a whatever else they see themselves as? Is there anything about your medication use you need to change to get the things that you want? How would things be in a year if you stayed the same? How would things be if things were different, and things and questions like that? The next piece is rolling with resistance. So again, we talked about this kind of riding reflex. So rolling with resistance, you're essentially adjusting your movements to the other person. So normally when we are confronted with resistance, the riding reflex kicks in. We try to directly counter resistance with like either persuading the patient to do something, cheerleading them kind of aggressively, using logic, data, essentially kind of scare tactics, anything that's logical and opposite of resistance. However, this is not usually helpful. And so in MI, resistance is never directly opposed. But that doesn't mean we're not working hard to elicit the opposite of what they're talking about. So you want to avoid arguing for change. So again, resist that riding reflex. We're not going to directly oppose something. New perspectives are invited, not imposed. So again, we're including the patient, making them an active participant to come up with other things or add information. Resistance is a signal to respond differently. So that should be a cue to you that, oh, the strategy I'm using is not working in my favor. I need to change it up and use a different strategy to get my patient to engage better with me. The person is a primary resource in finding answers and solutions. The patient should be the person that's giving you information instead of you trying to seek it out. It doesn't mean you can't ask any questions, and we'll get to, strategies and how to ask questions to get what you need. But primarily, we really want the patient to be providing the information. And then again, we're helping to guide them. I really like this idea. So keep this in mind. MI is dancing, not wrestling. It should not feel like wrestling. You should be moving, again, adjusting your movements to the other person. So you want to be taking in not just verbal, but nonverbal cues. You want to be essentially reading the room to know if the strategy you're using is effective or if you need to switch strategies. Supporting self-efficacy. So people know when we believe in them. If a patient is ambivalent about change and the clinician champions the side of change, that can actually be helpful. Now, it's not just like blind cheerleading them, like you can do this, you can do this. It's, again, helping take the information that you've already known. So a person's belief in the possibility of change is an important motivator. So we want to make sure that they have the belief in the possibility of change. We want them to be responsible for choosing and carrying out change. And then this is how we as providers can be helpful, is we can highlight past successes. We can highlight the skills and strengths that we see in our patients that will help them achieve change. So you can communicate optimism about the patient's ability to change and not just say, you can do this. I know you can make this change. There's a difference there. So when we are going to initiate MI, these are just some of the tips from Williams and Wright 2014 of how you can kind of check yourself before engaging in kind of more MI-based skills. So be aware of your own preconceptions about the things that you're about to engage in conversation with your patient. You want to have a non-judgmental attitude. So kind of check, again, yourself, your views, what you might be bringing into the room. Avoid using labels or diagnoses. A great way to kind of just establish autonomy from the get-go is asking permission to discuss topics further. It seems very simple, but it can really lay the groundwork. And this is where the time, like, it doesn't take much time to be like, would it be okay if I talked to you about this or asked you a few questions about this? That's very different than, I really want to talk to you about this today. It's simple, but it really does make a difference in building that alliance. And again, if you're going to be talking about change, you want that alliance as a present as kind of the backbone of your session. You want to assure your patients that you ask these questions of everybody to help them to, again, help normalize things and not help make people feel singled out. So again, that like expressing empathy piece. Acknowledge that you recognize that some information is difficult to talk about. So again, expressing empathy. within acknowledging that these things can be challenging to talk about. And then try to make things private. So depending on where you work and what the clinical, what the actual like environment looks like, try to maintain confidentiality for your patients as much as possible. And then during the conversation, like we talked about before, watch for nonverbal cues. Is the strategy or skill I'm using landing well, or do I need to change it up? So these are things to keep in mind when you're initiating a session, and kind of initiating motivational interviewing skills. So what are these skills that I keep mentioning? Core MI skills. So we're going to talk about a few today. One of the like basic fundamental skills of MI are the OR skills. And so that's O for open-ended questions, A for affirmations, R for reflections, and S for summary. So we're going to go through those together right now. So open-ended questions, these allow patients to explore their own ambivalence about changing. It puts patients in an active role versus a passive role in a kind of question answer trap. So you can see when you're asking people lots of questions, you can almost watch them physically disengage. So this is a way to not have to pepper your patients with questions, but get a lot of information. So open-ended questions. Here are some closed-ended questions, and I'll mention kind of how could we change these around. So you are here because you are concerned about your mental health, correct? An easy way to change this around to be open-ended. Tell me, what is it that brought you in today? How many children do you have? A way to turn this around is tell me about your family. Do you agree it would be a good idea for you to receive outpatient therapy? What do you think about the possibility of receiving outpatient therapy? Tell me about your depressive symptoms. Are you sad? I know that sounds a little silly, but I have been in the room with providers that have asked that exactly. Like that's a quote. So you want to be real mindful of how especially you're asking about things that could be very sensitive. So you may say something like, what does depression look like for you? Or what does your sadness look like for you? I try to use the words that my patient provides me to, again, help build that alliance that I'm going off of what you're giving me. I'm listening to you. When do you plan to start therapy? So when do you think it would be a good time to start outpatient therapy, or what does starting outpatient therapy look like for you? So those are ways to turn it from closed to open-ended. Some more examples here. So you can ask like more multiple choice questions, and the way to change that is, so will you decrease snack sodas or portion sizes to help your child's weight? What changes could you make in your child's diet to help your child's weight? Instead of a dichotomous question, do you want to stay in this relationship? Yes, no. How do you feel about this relationship? You want to avoid leading questions. You don't use corporal punishment, do you? No one's going to answer you honestly if you ask it like that. So you might want to switch it around and say, what forms of discipline do you use? Because then that also just like off the bat validates that like discipline strategies are common and you may most likely be engaging in them. And we're asking you non-judgmentally, what do you use? Whereas you don't use corporal punishment, do you? Definitely sounds judgy. Who takes care of your daughter when you're depressed and in bed? Tell me how your depression affects your ability to care for your daughter. So it's simple. Again, I say simple. It's not necessarily simple in the moment to come up with an open-ended question, but it's simple in that we're not changing the questions dramatically, but we're changing them just enough to land very differently for our patients and can really change how our patients then engage with us and engage in change talk. So for affirmations, compliments or statements of appreciation and understanding. So this could be commenting positively on like a specific attribute, a statement of appreciation, like I appreciate your efforts despite the discomfort you have in coming in. It could be a lot of different things. So again, praising positive behaviors, supporting the person as they describe difficult situations. Why do we want to give affirmations? Everybody likes to get affirmations. Adults, kids, teens, it doesn't really matter. Everybody likes it. It helps promote self-efficacy. It prevents discouragement. It helps build rapport. And it can reinforce kind of open exploration in patient talk, because if I praise something or give or affirm something, that patient might be like, yeah, and blah, 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 blah. So it's a way to get more information and not having to ask another question. So again, if we're peppering with questions, that can really put someone on the defensive or have a patient disengage. But these are alternate strategies to get more information, have the patient, again, being the leader of the conversation, or at least a very active role in the conversation. Now, the only caveat I have here is, it must be done sincerely. Patients, parents, teens especially, are going to see right through you if you're just like, thank you so much for sharing that with me, and you don't actually care that they shared it with you. They're going to see right through that. So really make sure your affirmations are genuine and sincere. Reflective listening. Oops. Oh, I thought I skipped one. Never mind. So sticking with affirmations for a second. So non-affirming statements might be something like, even if you smoke outside, your child can still be exposed to smoke. You have been making good efforts to reduce your child's exposure to smoke. Asthma controller medications really need to be taken every day. Even though you have had some challenges, it sounds like you've been trying hard to give your son his medications more regularly. Those land very differently, but you're still acknowledging that it's not completely where you may want it to be as a provider. And you're still affirming the pieces that have been done and the changes that have been made. Because we don't want to only focus on what hasn't been done yet. We also want to really affirm what has been done, what changes have been made, because that's going to set the stage for somebody to want to make more changes, because they feel like they could already make some change. So again, you're taking everything that a patient's telling you and you're helping guide them through this. You're really inconsistent with your use of timeouts. You've been using timeouts when you can and trying hard to use effective disciplining techniques. It's good that you cut down to half a pack per day, so now you can work on quitting completely. It's good that you cut down to half a pack per day. Cutting down is difficult, and you've done a great job. The next kind of core skill in the ORS is reflective listening. So this is a way of checking rather than assuming that you know what is meant. This is super helpful because people will also correct you if you're wrong. If you reflect back something and it gives them the opportunity to say, actually, no, that's not quite right, or yes, that's exactly how I'm feeling. So either way, you're allowing that patient to be active in their role of either correcting you or acknowledging that what you have understood is correct. So it strengthens the patient-provider relationship. It also can be used strategically to facilitate change, and we'll talk about that a little bit more later. How to form reflections. So there are different kinds of reflections. Reflections act as hypotheses about the speaker's meaning. They are presented as statements and not questions, so that's key, and we'll talk about that. And common reflection stems could be things like, so you feel, it sounds like you're wondering if, and you, blah, 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 blah. So those are some stems that you can use. There are simple reflections. So one way to simply reflect is just repeating back what you've heard. It adds little or no meaning or emphasis to what the patient has said, but it could be like, I want to start taking my medication again. You want to start taking your medication again. And it's important, again, to not end it like a question. So you shouldn't repeat it back as, you want to start taking your medication again? You want to start taking your medication again. It's that intonation is important. Because again, you don't want to just be peppering with questions. So when you can reflect it as a statement, it allows, again, the patient to either correct or acknowledge, yes, that's accurate. Another thing you can do is rephrase. So instead of repeating, you can rephrase or slightly alter what a patient says. So I really want to start taking my medication again. As the provider, you can say something like, taking your medication is very important to you. It's just a slight alteration of what was initially said. So those are simple reflections. Complex reflections can do a couple different things. So, for example, I want to smoke less. You can paraphrase, it's time to decrease marijuana use. So this is more of a major restatement in which the listener infers kind of the meaning in what was said and reflects that back in new words. There's also reflection of feeling. So you are unhappy with your marijuana use. No, in that example, there was no mention of happiness or unhappiness. You're inferring you are unhappy with your marijuana use. So that's a type of complex reflection. And then there's also double-sided reflection. So you want to be social with your friends, and yet you want to be healthier. This is assuming the smoking is happening in the context of, social contexts. So that's a way you can add a little bit more into the reflection. All right. So here are some more examples. So providers you want to avoid, it really would be best for you and your kids if you got out of this violent relationship. A reflection instead could be, it sounds like there are still a lot of good parts to this relationship that you don't want to lose. I really think you will only get better if you take medications. Although your depressive symptoms are upsetting and you think medication may help, you are concerned that the side effects of medication will make you feel worse. Sometimes I also like to, so these aren't my examples, but the way sometimes I would alter some of these examples is I like to end on the statement that elicits more change. So I might say, like, you're concerned about that the side effects of medications will make you feel worse, and your depressive symptoms are upsetting, and you think medication may help. So it kind of sets the stage for medication may help. What should we do with that information? So again, it also then helps outline discrepancies. Another example, even though the insulin shots hurt, it is important to give them to your son to prevent health problems. It is difficult to give your son shots when you know they hurt him, and you also don't want him to have the long-term effects of uncontrolled diabetes. So I put and in there because it had but before, but I just used but and from a DBT perspective or dialectical behavioral perspective, we want to hold both of these things in the same space. So I tend to just use the verbiage and not use but, because these things are both true. It is really difficult for that person to give their son the shots, and they really don't want those long-term effects from uncontrolled diabetes. So both of those things can exist in the same space and time. The amount that you're drinking really could affect your children's health. Right now, you feel like the amount you're drinking won't hurt your child's health or your children's health. So again, that reflection is, you can sometimes be gently confrontational with reflections, especially if you can use the patient's own words. Somebody might hear that back and say, well, no, it is hurting my child. And then you go, okay, so your use is hurting your child. And that's pretty impactful for somebody to hear and have to correct you with. So these reflections can be really useful in, again, supporting change talk. Now, it might feel strange to make statements instead of asking questions. It might feel like you're telling a person what they feel or what they're saying or thinking. So this is a muscle really that you want to think about this in your sessions, outside of your sessions. You can practice this with colleagues, with family members, whoever, because it doesn't feel natural at first. But then once you get the hang of it, it's kind of like, I don't even know how I used to do it. You build it as a new muscle and it becomes your new normal. Summaries. So summaries can be used to begin and end a session, as well as transition between topics. Strategic summaries, so you select what information should be included and what can be minimized or left out. So you get to pick and choose what you want to include. And this is, again, a muscle that you'll build, but you want to try to pick out change talk, and we'll talk about that in a few slides of like what that is to summarize back to people to, again, set the stage for continuing change talk. So it could be, for example, statements like, I could do this, or for this to happen, I would need this, stuff like that, to then summarize back to then again support further discussion of that topic. Double-sided reflections can also be used as summaries. And then do not try to problem solve, give advice, or change / add anything you heard. Just summarize what you hear and maybe add what you think is the underlying meaning or feeling or a complex reflection. So A summary should not be problem solving. It should not be you giving the patient advice or notably changing what you've heard. All right. And then another way that summaries could be helpful is you can kind of gather everything and then provide it to a patient almost as a menu of options. So if that patient's talking about a lot of different ways to change, you can help again organize it, set it there for your patient in a more organized way, and then as a guide, and then the patient still gets to decide which path they take. So you want to avoid saying things like, how about you try using timeouts instead of spanking? A way to summarize differently is, you don't feel that your spanking will get out of control, and you'll consider using timeouts if you get really angry. So it sounds like there are a lot of reasons for you to quit drinking. On one hand, alcohol helps you socialize and relieve stress, and you don't want to stop drinking right now. On the other hand, you feel like it can lead to problems. The plan should be to take your son to the playground for exercise and replace the processed snacks with options like cut up vegetables and fruits. It sounds like you're interested in finding ways for your son to get more exercise through play, and you're thinking about trying healthier snacks. And you'd like to brainstorm ways to accomplish these goals. If you don't take care of yourself, you won't be able to take care of your children. You would like to get treatment for yourself, and you will try, and you're not sure if you'll find the time. So this is where I would swap it a little bit if I was the provider. And I would say, you're not sure if you'll find the time, and you would really like to get treatment for yourself, and you're going to try to do this. To again, end on the topic that promotes more change talk. Okay, so change talk. What is this change talk she keeps referencing? So change talk is patient talk that leans in the direction of change. It sounds easy, but sometimes we don't hear it. Sometimes we get so focused on other pieces of what our patients are telling us, or thinking about our note or filling in the templated note during session, that we miss out on these pieces of change talk. So again, change talk is when a patient expresses motivation for change, and the conversations we try to elicit can fall into this kind of what we call the acronym DARN CAT. So a desire, so patients stating something like I want or I wish. Ability, I can, I could. So those are the statements you want to look out for if your patient is saying those words. Reason, if I can, then I can, or I would feel better if. Need, I have to. Commitment, I will, or I am going to. Action or activation, I'm ready to, I will start tomorrow. Taking steps, I actually went out and this week I started. So what did they actually do? Those are the types of language kind of stems you want to be thinking about and looking out for, because then you want to reflect those back. You want to affirm those. You want to do all of the or skills to then help promote more change talk. This is getting them to that action phase, hopefully, where we are then saying, okay, or really the preparation and action phase. What is it going to look like? And how can we start engaging in actual behavior change? Okay. The other ways to elicit change talk is asking evocative questions. So like, what concerns you about blah, blah, blah? Why are you thinking about making a change? And why would you do that? Now, I try to stay a little bit away from like a bunch of why questions, but it's not like you can never ask why. You just want to not use it too often, because it can sometimes feel a little off-putting to the patient. But you want to kind of ask a little bit. Sometimes it is really helpful to be like, why do you want to change? You can ask for elaboration. So when change talk theme starts to emerge, ask for more detail. So what thoughts do you have about that? Or what other ways in which you might be able to deal with that level of responsibility and stress without smoking weed? So again, ask for elaboration. Ask for examples. So like, when was the last time that happened? Give me an example of what else? Asking kind of open-ended questions. Looking back, ask about a time before the current concern emerged. So how were things better or different before blah, blah, blah. This is particularly helpful for patients who have had periods of engaging in helpful behavior. So again, Thinking about all the way back to the beginning, highlighting strengths, highlighting past successes, this can all help promote self-efficacy. So was there ever a time this, or I remember you telling me there was a time you're reflecting, you're using the patient's words. Tell me more about that. What was that like? How were things different when you smoked less? How are things different when uh, you know, had a better relationship with so and so? Look forward. So ask what may happen if things continue as they are. Particularly helpful for patients who don't seem to have interest in changing right now. And then another is like querying extremes. So what are the worst things that might happen if you don't make this change? What are the best things that might happen if you do make this change? Exploring goals and values. So ask what the person's guiding values are. What do they want in life? So this, if you're familiar with acceptance and commitment therapy, you can think of kind of the value-driven actions within ACT. Does it help to kind of realize a goal or value, interfere with it, or is it irrelevant? You want to read again the room. Is this a helpful strategy to promote change talk in this patient or not? And then again, are their behaviors discrepant with their values? You want to come alongside. So this is kind of explicitly siding with the side of ambivalence. So perhaps blank is so important to you that you won't give it up no matter what the cost. That is also kind of evocative in nature. It also is a reflection, that a complex reflection that might lead your patient to be like, no, there's a cost. I don't want to do this if blah, blah, blah. And then you reflect back, you don't want to do this if blah, blah, blah. And again, that can just help promote the discrepancy that then helps promote behavior change and change talk. And then decisional balance. This is one of the tools I use often in treatment. So you basically are thinking about what are the pros and cons of if things stayed the same or if things changed. You will oftentimes find that, and I don't add anything. I have the patient come up with everything in those 4 quadrants. And what you often see is that their lists are longest for the pros of changing and the cons of staying the same. And then that's a nice way to just be like, I didn't say any of this. This is something that you came up with, and it takes less than 5 minutes in session. So it's a quick, easy tool to basically show where someone is at. Now, if they're in the early stages of behavior change and they don't even identify a problem, probably not the best skill to use because they don't identify their behavior as a problem yet. So that's where you might want to be building more awareness, slight education around risk, assessing risks, things like that. But when you're in that kind of contemplation stage, this could be really helpful to work through some of that ambivalence. Another strategy is a change ruler. So I often, again, use this in sessions where you want to gauge what is, how important does somebody find this behavior change? How confident do they feel in being able to make the change, and how ready do they feel to be able to make the change? And so I often ask for them to rate it on a scale of 0 to 10. So 0 is like not at all important. 10 is very important. And then let's say they give me a 5. I would say, what made you say a 5 and not a 3? Because like 5 was pretty good. And then you want to end with what would need to happen to move that 5 higher up on this ruler. So how can I support you? What do you need in your environment? What do you need in your support system? What is it that is going to help support you towards getting to your goal? Because somebody might find something very important. They might feel very confident, but they might not be ready. Or somebody finds it very important and they feel ready. They're just not confident that it's going to work. So this helps you. This is specifically or really important, especially important for the patients where it's like they seem like they're in the preparation stage, but like they just can't get to the actual engagement in a new behavior. This is really important because it's something must be missing or something must be lower on the ruler that we need to support to get the actual change to happen. So that's another skill that can be helpful for providers. So in summary, the spirit of MI, you want to respect that patient's autonomy. You want to collaborate. You want to evoke from the patient. What do they view as the problem? What do they want to change? If we're not sure what they want to change or if there's a problem, we can use open-ended questions to gather more information. We can affirm the things that we want to affirm to, again, help build alliance and help build self-efficacy. We want to reflect back to them because it's way easier to do reflections than pepper questions and come up with your own hypotheses on the spot. Use what the patient gives you, use their own words, because that just helps build alliance. It makes it easier for you. And then it also helps guide the conversation. And then utilize those summaries in effective ways to get more information and to, again, set the stage for change talk. Through all of this, you want to make sure you're rolling with resistance. You don't want to argue. It's a dance. You're not wrestling. You want to, again, express empathy. You want to develop the discrepancy between current behaviors and values. And then you want to support self-efficacy by recognizing and referring back to past successes of the patient, the strengths of the patient, skills of the patient, and then again, just like instilling a sense of optimism that they have the ability to change. Once we hopefully get to those change talk kind of parts of the session, we want to think about darn cat. We want to think about, am I hearing any stems for change talk, and how can I affirm that and build off of that to then create an actual behavior plan? So thinking about the commitment activation, taking steps like, I've already taken the step, or I'm going to, I'm ready to. And then if you're still sensing some not, ambivalence around it, using our change ruler or using the pro-con decisional balance tool to really tip the scale into creating a behavior plan. This is just a checklist that you can kind of check yourself of like, am I like in line with the spirit of MI? So like, do I listen more than I talk? You should be listening more than you're talking. Again, this is why it can help with provider burnout, because it puts the burden on the patient really to come up with the information within the session. Do I keep myself sensitive and open to this person's issues, whatever they may be? Am I non-judgmental about this? Have I checked my own biases at the door? Am I presenting myself in a genuine way? Do I invite this person to explore their own ideas for change? Do I encourage this person to talk about their reasons for not changing? Do I ask permission, respecting that autonomy? Do I reassure this person that ambivalence to change is normal, build that self-efficacy, and so forth. So these can be really helpful, again, to just like make sure, am I doing things in line with the spirit of MI? And then finally, an example session with like a parent could be, you assess for risk factors using open-ended questions. You get a lot of good info. You follow up with more specific questions, because it's not like you're not allowed to ask questions. You just want to minimize them. And by open-ended questions, you'll get more information that way. You ask for permission to discuss a topic further as it pertains to the child's health. Then you can ask about readiness for change. You can ask about confidence for change. Based on the parent's response, you can affirm or reflect. You can ask more open-ended questions if you need more, or if you want to elicit more change talk, and then collaborate on goal setting and what is that going to actually look like, and then summarize that to family. So that's just like a nice way of outlining what this can look like in a session. Now, you might not get here in the first session because maybe they're not in a place for even thinking about change. Maybe they're in that pre-contemplation. That's fine. Then you focus on getting as much information, educating and assessing risks, and respecting autonomy. If a person isn't willing to change their first session, if you can build the alliance in that first session, the hope is by session 2, 3, 4, they start to talk about change with you, because you haven't pushed it and you haven't done a fully, you haven't taken a directive role. It's been more guiding. So those are just things to keep in the back of your mind when you're having conversations with patients about difficult topics or around topics related to behavior change that are oftentimes challenging for patients to have and providers to have. So hopefully the skills talked about today can be helpful. I'm going to stop talking now and just ask if anyone has any questions.
Thank you so much for that wonderful presentation, Dr. Segan. Please place any questions that you have in the chat or the Q&A function, and we can get to them.
So I think Grace added the Miller-Rolnick guiding the book,
Yes.
engaging, motivational interviewing. That's a great resource as kind of an introduction to motivational interviewing. So I encourage use of that book as just kind of a introduction and good review of skills.
We had
Okay, so I
oh yeah, go ahead.
Oh, I was just going to say I saw Amy's post of what about additional training opportunities to practice these MI skills. So that's a great question. Um, so there are everything costs money. So there are rarely like free MI skill building practice, or online to, didactics. I would, depending on I'm not sure which group you're part of, but like I'm always happy to talk about MI. So like I've given some MI talks within Hopkins. I can also look up different resources and see if I can compile any resources because I haven't looked in a little bit. And so there might be some new things out there. But there can be trainings if you have speakers come in and train on them. I would say the Miller-Rolnick book is like a really good book. So I would invest in that as just a kind of intro again and review of today's things. But I'll look into that because I don't know of if there's any kind of free or online didactics that could be helpful from a training perspective. So I'll check into that, Amy, and I'll let Lily know, and then she can provide those resources if I find any.
Yeah, absolutely. Oh, I got a question to me. So as a primary care provider, like how would you recommend starting implementing these into like well visits with patients?
So, I mean, I think you can start from the very first intake session. So knowing that time is limited, I would think ahead of time, what are the open-ended questions that are going to give me the most about what I want that are relevant to what I want to get out of the intake with this patient? Because you don't want to ask too many open-ended questions, and you don't want to ask an open-ended question that might open a box that you can't close in the first session. So you want to think, what are the ones that I absolutely need to get? So if you know the referring or the primary concern, again, kind of thinking ahead, prepping what are good open-ended questions to get what I want out of this intake. The other thing simply also is asking permission. A lot of people look at me, a lot of my patients look at me kind of like I'm odd when I ask, like, would it be okay if I asked you a couple questions about this? They're like, yeah, I'm already here for that reason. But then I can kind of see them relax. So again, this is where it can feel a little awkward, but like asking permission, is it okay if we talk about this today? I'd love to know more about this. Can I ask you some additional questions? And then I think really reviewing the way you're asking your questions. So if you've got a good script already in your mind of how you ask questions in your intake, think about, can I switch this around so that maybe it feels a little bit less like you should be doing this, or not that anything would like inherently come off as judgmental, but like thinking, is there a way I could reframe the things that I'm already asking in a way that make them more neutral? And then you can just kind of, and then the OR skills, right? So the open-ended questions, the affirmations, reflections, all of those things you can start in your first session. Now, if you identify a problem behavior or a problematic health behavior that the patient or family is engaging in the first session, then you don't necessarily have to, I mean, it's going to really depend on like where the patient is at. So keep in mind the stages of change. Like, do they even identify this as a problem? If not, I'm going to be just identifying what are the risks and has anything bad happened related to this behavior that I can reflect back to be like, and it doesn't seem super helpful when when you do this. So think, where are they at in the stage of change? And then what kinds of skills can I use to emphasize the discrepancy if that's where I need to be? Or if they're like, I know this is a problem, I want to change this, I just don't know how to change this. Then you go right into, okay, fantastic, affirm them and their insight into wanting to change. And then talk about, okay, what would change look like for you? When would you want to start? Instead of you coming up with the plan for them, put it on the patient of like, when are you thinking about starting? What would that look like? What barriers could get in the way? How can I be helpful in supporting you in this? Or using the decisional balance scale, using kind of those change talk skills. So in summary, think about, where are they in the stage of change? And then utilize the basic skills we talked about today to move them forward in that cycle.
Great. Anybody has another question, last minute question, put it in the chat. All right. I think that's it for today. Thank you so much again for this wonderful presentation, and to our attendees in today's session. The recording for today's session, the slides, and a list of related resources will be available on our website next week. We'll send CME and CU certificates to participants by January 3rd. Please remember to take the survey that was placed in the chat as you leave, because it's required if you'd like to receive a CME or CU certificate. And we'll also send it out via email after the session as well. And stay tuned for future BHIPP resilience breaks and other BHIPP trainings by following us on LinkedIn, Facebook, or Twitter. And thank you so much again. And I hope everyone has a great rest of their day.
Thank you all so much.